the site that she just left. And so there seemed to be a very tight communication that she had with the anesthesiologist in particular cases, right? Where the other OBGYN that we interviewed basically had a little bit more of your kind of approach, which was, it's them, right? I'm not involved at all. So,
okay, let me help you understand where I'm coming from. Those are very useful observations. First and foremost, when you deal with reproductive age women, most of whom in my practice are older reproductive aged women who are professionals, who, like the attorneys and everybody else who are in my practice, are also physicians or other professionals. And I've operated pretty much on maybe half the women physicians in my hospital. And I'm in really tight communication with them at the beginning of the case, because I'm known to be somewhat of a stickler. I have my patients pretty much standing on their head in very deep Trendelenburg. And that's a huge problem for not a huge problem, it's a big problem for anesthesia, because it decreases lung volume, the tidal volume, the residual volume. It predisposes people to post-anesthesia atelectasis.
Why do you have them in this position? Is it a...
Because I'm a gynecologist, so where do I operate?
Yeah.
In the deepest part, the bottom of the abdomen, the pelvis. Yeah. If you're standing up, you have 32 feet of bowel. Where does it go? It goes down. So I can't swim around. 90-odd% of my cases are laparoscopic. So I can't just keep throwing in little 5-millimeter tools and trying to scrape bowel away. If you've ever played with bowel in a cook or anything, it's kind of slimy and it'll slide right back around. So what we do is we take advantage of gravity and we tilt them and the bowel all goes down and
it exposes what you need to get at.
Yeah. And it's in those 32 feet of intestine and its contents hit the diaphragm,
pushes against the lungs,
pushes it up.
They aren't happy with that.
So they have to do mechanical ventilation, and that changes everything.
Is your approach typical, like for C-sections? Is that?
We don't do it at all for C-section.
Oh, okay. Okay. So this is
C-section is the uterus pushes everything else out of the way.
So this is for regular, some kind of gynecological surgery. You would always set them.
Pretty much all laparoscopic procedures are like that. Okay. So the other thing we have them do is we put an NG tube in every single patient, because that decreases the stomach volume. There's a lot of air, especially before you put a patient to sleep. You're masking them and you're forcing air through, and a lot of it gets forcibly down through the esophagus, not just the trachea, because you don't have anything in yet, the trachea. And so you're pretty much blowing up their stomach. So I insist on an NG tube, nasogastric tube, to deflate the stomach and aspirate contents. So whatever I can do to get bowel out of my way is what I need. And then the anesthesia people sort of have to deal with the problems of, mechanical ventilation in that scenario.
But you're saying in the beginning of the case, not during the case, but at the beginning of the case, you're very interested in the team as far as working with the anesthesiologist.
Totally.
And are they hemodynamically unstable? Do they have cardiac issues? That pain or not?
These young reproductive age ladies, as an example, probably compared to two, let's say, 70-year-old ladies, probably have less in the way of cardiovascular types of concerns. And so, as I was saying earlier, I haven't had sufficiently ill patients that I've needed that, except back when I was in training and was working on older oncology patients.